Um, this is our prostate awareness campaign. As I said, I've been working with Linda and Lauren from Unique Improvements, and this campaign has been funded by the West Yorkshire and Harrogate Cancer Alliance. Um, and I'm going to talk to you a bit about what we've been trying to do and what we're trying to achieve. And please do feel free to interrupt if you object with anything. Let me know. I'm happy to take any feedback as we go, and there'll be opportunity for questions at the end. So we're going to talk about why we think this project's important, the timeline, and particularly Linda and Lauren have been working hard to work on the timeline. We've got some brief community insights about why people in the community think it's important as well. And then we're going to talk a bit about prostate, and particularly about prostate cancer and testing, and what we're hoping to achieve, hopefully with your input as well. So as I said, the Prostate Awareness Campaign is funded by the Cancer Alliance, and it's running from April of this year to March of next year. And our aims are to increase the awareness of prostate cancer and hopefully encourage men to seek a prostate health assessment with you guys in primary care. And we've got two main components of the project: to provide training and education to both clinical and non-clinical staff related to prostate cancer and PSA testing in particular. And the second facet of the project is to raise awareness in community groups around prostate cancer, and particularly peripheral and at-risk groups, which we'll come on to shortly. So some background about prostate cancer. I'm sure many of you know these facts, but it's worth doing a bit of revision. So prostate cancer is the commonest cancer in men in the UK. Over 50,000 men are diagnosed each year, and more than 12,000 men die from prostate cancer, and it's only second to lung cancer in terms of the number of deaths of cancer in the UK. So it's a huge health economics problem as well, and it carries a large morbidity and mortality with it. 1 in 8 men, such as myself, will be diagnosed with prostate cancer in their lifetime. But as you know, many men will be diagnosed later in life, and it's something that they live with rather than die from. But what you may not know is 1 in 4 black men will be diagnosed with prostate cancer in their lifetime. So black men are at twice the risk of prostate cancer. And it's a kind of triple-edged sword, really, because black men get more aggressive cancers. They tend to present later, so they typically have advanced disease at presentation. And we know that our current health interventions and health promotion, relating to, health awareness at the golf courses and that type of thing, doesn't reach these groups of men. So we know that our current health education for the black community is lacking. And that's something that Linda and the team are working hard to address. We know that there's social and ethnic health inequalities, and these impact referral rates. So we see most referrals in Leeds from North Leeds and West Leeds, so the more affluent areas of Leeds. And conversely, we don't see many referrals from South and East Leeds. And typically we see a stage shift. So the lower social economic groups and the higher ethnic diversity groups, they typically tend to present with later cancers. What you may not know, and what hopefully I'm going to teach you today, is that we've made huge advances in recent years relating to prostate cancer diagnosis in particular, but also treatment as well. And from my point of view, I feel that the scales have tipped in favour of early PSA testing, particularly in those groups that are at risk of prostate cancer, such as the black community. So, again, why do we think this is important? This graph at the top right of the screen, this map, shows us that we're at the top of a league table in England that we don't want to be top of. So 1 in 5 patients that present in northeastern Yorkshire will present with advanced disease at presentation. This cannot be cured. And you compare that with London or the southeast, it's significantly lower. So just 12% in London and 14% in the southeast. And we're only behind Scotland, where 1 in 3 men present with advanced prostate cancer. And as I said, if we pick up prostate cancer early enough, we can cure men. Almost 100% of men present with stage 1 cancer can be cured. But once it's spread outside of the prostate, it's a non-curative option, unfortunately. And this graph at the bottom of the screen highlights the cliff edge that we saw during the COVID pandemic, where we saw a huge drop in referrals. And since then, we've been working hard to kind of find these men that should have been presenting during that time, and now our referrals have gone beyond where they were pre-COVID. But clearly, there's men that would have presented during this time which haven't done so. And anecdotally, I feel like I'm diagnosing a lot more advanced prostate cancer, in these years, which is something we want to address really. And there's a clear north-south divide here between the advanced presentation. So the timeline that Linda and Lauren and the team are working towards, earlier this year, they were doing some insight gathering and finding out what's been done previously, what works elsewhere, and what we might plan to do. From September through to March of next year, we're looking at these sessions for both clinical and non-clinical staff, looking at education and raising awareness. And then in the new year, up to spring, they'll be working on some community awareness events. This is some work that Linda and Lauren and the team have done previously, looking at community insight, and they asked men, what their thoughts were about testing for prostate cancer and PSA testing and things. And there's some really, really prescient points here that hit home, and I've highlighted some of these in black. So the DRE puts people off, and again, we see that particularly the Black community do worry disproportionately about DRE examination. Having a female doctor is a point that came up as well, and some practices, getting access to a male GP can be difficult, and patients wouldn't want a DRE examination from a female doctor. The embarrassment around prostate health as well, and sexual health as well. Talking about the prostate's embarrassing, and again, people are scared of DRE. So I think these points kind of really hit home with me, because we make a lot of assumptions, particularly in secondary care, about what patients want. But these points are really, really valid, I think. And we also asked men if they could put a message on a poster about prostate cancer, what would that message be? And some of the points that came up again really kind of hit home, making the point that it's a small discomfort that could save someone's life. Saying it could affect the family, so some kind of emotional blackmail there. If you don't go for you, go for your family. Some information about prostate cancer being curable if it's caught early. And important that we're not lecturing patients, trying to encourage them to get tested, and raising the point that actually patients can be very scared. Men can be very scared of the diagnosis, and we see that all the time, don't we, with kind of patients burying their head about things. So we need to address these issues in the community as well, really. So a brief bit about the prostate. I'm sure many of you are aware it's a gland sat between the bladder and sat around the urethra. It's usually, in most men, the size and shape of a walnut, but it gets bigger as you get older, physiologically. And obviously, as it gets bigger, it presses the urethra, and that's why men get urinary symptoms as they get older, getting up in the night, etc. And its main job is to produce semen, which obviously transports the sperm. But you can live without your prostate. It's important to mention that not just men have a prostate, so trans women as well, non-binary people who are assigned male sex at birth, and some intersex people with both female and male sexual characteristics may have a prostate too. So it's important to identify these patients in your community as well and consider their risk of prostate cancer. And we know from previous research, the trans community don't always appreciate that they may be at risk of prostate cancer too. These are the typical signs and symptoms that we tell patients to worry about with prostate cancer. So urination, weak flow, blood in hematospermia, so blood in the semen, blood in the urine, getting up in the night, erectile dysfunction. In actual fact, most prostate cancers are asymptomatic, and hopefully this diagram explains why. You need quite a large cancer in order to press on the urethra or to involve the neurovascular bundle, which causes erectile dysfunction because the nerves sit here. Most cancers we pick up, at an early stage would be kind of a centimeter or so. So typically when men present with symptoms, it's often too late, or their symptoms aren't related to the cancer, but they're related to benign prostatic enlargement, which is why I'm quite keen, even for asymptomatic men at risk, PSA testing is really important, because often if you wait for symptoms to develop, then it can be too late, and that can actually signify locally advanced prostate cancer, which can be curable if it's locally advanced, but it does make things more difficult in terms of surgery and radiotherapy options, etc. So, on to PSA testing. The latest NICE guidance states that PSA testing should be considered in men with suspected prostate cancer. So, no surprises there. But what some of you may not know is that the latest NICE guidance says that the PSA test should be offered to men older than 50 who request a PSA test. And it's available to anyone with a prostate, like I said previously, so the trans community and non-binary patients as well. So, why is PSA testing so controversial? So why don't we screen for prostate cancer now? And why does it rely on patients, men, coming to you, requesting a PSA test, rather than you saying to them, Mr. Jones, it's now time for your PSA to be checked? Well, the PSA is sensitive, but not specific for prostate cancer. As the name suggests, it's a prostate-specific antigen, so it's only secreted by the prostate, but it's also raised in things other than prostate cancer. And historically, there was a risk of overdiagnosis of low-risk cancer. So that's a cancer that's not going to kill the patient, not going to harm their quality of life. And there was a risk of post-biopsy infection with a transrectal biopsy, as shown here, where we passed the needle through the rectal wall. The risk of infection was around 5%, so not insignificant. We've made huge changes now. So now we do a pre-biopsy MRI scan, what's called a multiparametric MRI scan, which is a posh way of saying we do lots and lots of sequences. And we do what's called a transperineal biopsy. So instead of the needle going through the rectum, the needle goes through the perineum, which is the skin overlying the prostate. So the risk of picking up low-risk cancer is reduced with pre-biopsy MRI, and the risk of infection is reduced with TP biopsy. So from my point of view, the pendulum is shifted in favor of early PSA testing. As I said, the PSA is not a perfect test, but it is useful. And depending what your cutoff point is, as your PSA increases, your specificity increases, but your sensitivity reduces, basically. There's a lot of false negatives. So 1 in 7 men with a normal PSA will have prostate cancer. So it doesn't exclude all people with cancer. And it's typically, it has a high false positive rate. So around 3/4 of men with a raised PSA will have a negative prostate biopsy, so they won't have prostate cancer. And it's important to say that when you refer men with a raised PSA on the 2-week wait pathway, not all men will end up with a prostate biopsy. And from the MRI, we managed to discharge around 30% of patients at that point. Just to touch on the DRE, this is a pooled kind of systematic review of the sensitivity and specificity of DRE. And this showed that the sensitivity is very low, but the specificity is high. And what this is essentially saying is DRE shouldn't be used as a reassurance tool. And occasionally I see men referred in with a raised PSA, we'll say for argument's sake, the PSA of 10, and they have a DRE with their GP, and the GP says, oh, don't worry, you've got benign enlargement, your prostate's smooth. But actually, there's an awful lot of the prostate you can't feel with your finger. So if you have an abnormal DRE, that has a high specificity. So if you have an abnormal DRE, the chance of there being cancer is quite high, but a normal DRE can't exclude cancer. My take home from this is the DRE is fast becoming redundant with telephone clinics, both in primary care and in secondary care, and also with the MRI scans that we do now. There's no need to do DRE anymore, and it shouldn't preclude you from testing the person's PSA and referring the patient onto the 2-week wait pathway. And I hope that message, you take that message home with you, because that's really important. And we've seen, obviously, men aren't particularly fond of having an examination either. And if you're having a telephone clinic appointment, you may need to call the patient in for a DRE. It's just a waste of an appointment, I think. If the PSA is raised, refer them on the pathway, and we'll do the rest for you. Looking at MRI, so pre-biopsy MRI, this was a study that was done in London in 2016. This is called the PROMISE trial, and this gave us all the evidence for pre-biopsy MRI, essentially. Pre-biopsy MRI has a negative predictive value of nearly 90%. So if you have a negative MRI scan, your chance of having cancer is very, very low. And we've got some MRI pictures across the bottom here. So the green arrow shows you there's a small tumor there, and we've got This is a T2 image where you can see the cancer there. This is diffusion weighted, where we see how cellular that area is. And this is when we give contrast. Here's the rectum at the back, and this is the prostate, yeah? So you might think, well, actually, if you're examining this patient, you might feel a nodule there. And if you're doing a trus biopsy, which is what we used to do, putting a needle through the rectum, we're going to hit that. What you won't be able to feel with your finger, and what we won't be able to feel, what we won't be able to access with our transrectal biopsy, is this tumor at the front here. And again, we can see that just about there, but we can see it much more clearly on the diffusion and the contrast imaging there. This tumor was Gleason 8. This tumor was Gleason 7. So that has a real bearing on the treatment for the patient and the life expectancy, the prognostication of the patient as well. And this is why I suggest that DRE is fast becoming redundant, because had this tumor, the posterior tumor, not occurred, you would say, well, this prostate feels normal, but you'd have no idea about this. It doesn't matter how long your fingers are or how thorough your examination is. You cannot feel that with your finger because it's at the front of the gland, yeah? And this just shows when we used to do trus biopsy, we'd take about 5 biopsies from each lobe, so 10 in total. But often we would skim a significant tumor presented by this red lesion here. We might miss entirely a lesion more anteriorly placed, but we might go straight through a small insignificant tumor like a Gleason 6 tumor here. And that's just showing how MRI has changed. And here's another example of a tumor here, which you may be able to feel on examination, but again, shows you what that looks like on an MRI scan. And this shows you, I hope no one's having their lunch at the moment, this shows you what we do for biopsy now. So traditionally we did a transrectal biopsy where we passed the needle through the wall of the rectum into the prostate. Obviously the rectum is a dirty place. Despite giving it antibiotics, despite trying lots of things over the years, rectal douching, all that type of thing, the risk of infection has always been around 5%. And we've seen antibiotic-resistant organisms, particularly ciprofloxacin-resistant E. coli, develop over the years. Whereas now we do a transperineal biopsy where we put the needle through the skin over the prostate. This is really well tolerated. It's done in the outpatient setting. It takes me about 10 or 15 minutes under local anesthetic. The men do really well, and they go home, half an hour after the procedure. They may have a bit of hematuria for a few days, but it's a much better biopsy, much safer, and also we can get to parts of the prostate that we can't get to with a trus biopsy, particularly the front of the prostate. And this is just to show that we can do fusion biopsy as well, where we take the MRI scan and we fuse it with the ultrasound image, and we can plot where our biopsies are taken from, so we can provide a really accurate, really safe biopsy as compared to the old type of trus biopsy. This is the current pathway which NHS England have laid down. This is the gauntlet that they've set us. So from referral from you guys being day 0, the patient needs to be triaged, have an MRI scan, have a biopsy, any further investigations, so CT scan or bone scan, etc., be discussed at the MDT, and then be seen back in clinic by day 28. There's an awful lot to do here. We're not particularly terrible in Leeds. We're fairly average throughout the country. If you'd come to me 12 months ago, we'd be looking at day 90 for this. We've done a lot of work in the interim, so we're now at about day 50 for the whole pathway. We know that there's pinch points, so prostate biopsy has been a problem up until recently. So now we're booking prostate biopsies within a week now, but that was 3 or 4 weeks 6 months ago. And getting the pathology ready for the MDT can take a couple of weeks as well. But we've been working really hard to streamline our pathway to try and meet this 28-day target. So the old pathway, as 12 months or more ago, referral would come in from the primary care. The patient would be seen in clinic, usually a face-to-face. Then they'd have an MRI scan booked and requested. Then they'd have a telephone clinic to discuss the results. Then they'd be booked for a biopsy. Then once everything was ready, they'd be discussed at the MDT and then back to clinic. And you can see with all this friction and all these touch points how things could take up to 90 days. Yeah, if it's a week from GP referral to clinic, and then a week to the MRI scan, a week to discuss it, 2 weeks to the biopsy, 2 weeks to results. Before you know it, you're at 2 months. What we do now, when the 2-week wait referral comes in, we have a remote triage by our urology nurses. So they pick up the referrals usually the following day. They will phone up the patient just to confirm all the details that's been given on the triage, and they'll be booked for MRI scan, if not the same day, the following day. So they'll typically have an MRI scan within a week of being referred by the GP. As I said, we're offering a biopsy now within a week of the MRI scan as well, and then we get them back to the MDT within 2 weeks. So at the moment we're working to around 6 weeks for this pathway. I do want to speed things up more, and I'll mention that shortly. And this again just shows some of the MRI scans and the ultrasound imaging that we use. So what does this mean for you in primary care? Well, hopefully I've convinced you that the reasons not to check a man's PSA are quickly diminishing. What I'd like to plant the seed of with you is opportunistic counselling particularly amongst at-risk men. And if you're seeing, for argument's sake, a 52-year-old black man who's come in for something totally unrelated, so a chest infection, maybe some back pain, but you know that you've not seen this patient for the last 10 years, and in all likelihood, he won't be back to you for another 10 years. Is that an opportunity to discuss about his risk of prostate cancer? Is there any family history of prostate cancer? Is he aware of prostate cancer? And just thinking about, is this something to discuss at that time, really? And please do offer a balanced opinion on the pros and cons of PSA testing. It's not for everybody. Clearly, if you've got comorbidities, if you're getting to an age, kind of above 70, 75, and your PSA has not been raised in the past, then there's an argument that you don't need to check it again. But please don't discourage men coming forward who've requested a PSA test. And unfortunately, when I'm doing biopsies, I ask patients, how they've ended up here, and they've said, well, my friend was diagnosed at the golf course. I thought I'd get checked out, but it took me 2 or 3 visits to the GP because they said, a PSA wasn't for me, or, have I thought about the risk of prostate biopsy, risk of low-risk cancer? Hopefully, I've shown you that actually the risks associated with PSA testing in the prostate cancer pathway are significantly reduced now with all the fantastic advances that we've made. The final thing, we're looking at using artificial intelligence in Leeds as almost a triage tool. I'd like to move towards kind of a one-stop shop for prostate cancer, as they do for breast cancer, where women have obviously all the investigations they need in one day. So for breast, it's mammography, ultrasound, and a biopsy if needed. What I'd like to do is do an MRI scan in the morning, and if the patient needs it, have a biopsy in the afternoon. It'd be a long day for the patient, but it would certainly speed up the pathway. And I'm looking at using artificial intelligence for this, where when the patient's had their scan, the AI tool is working in the background, deciding whether that patient should have a biopsy the same day or not. And I'm working with a company based in Cambridge. They have a tool called PI, Prostate Intelligence, and that picks up hotspots in the prostate, which would then be reviewed by myself or one of my colleagues when we're looking to book the biopsy. Patient won't have a biopsy obviously without a specialist radiologist review. But I'm hoping we can use it as kind of a triage tool to make the more abnormal scans float to the top. So that's kind of work in progress at the moment. Potentially that's going to be really, really exciting, particularly if we can move to kind of a one-stop shop or kind of a rapid diagnostic clinic type setup. So I'd be interested in your feedback on that too, really. And just to say, there's an awful lot going on in prostate cancer at the moment, with the sad news about Sir Chris Hoy as well being diagnosed. He had no symptoms. His first symptom was scapular pain, so shoulder pain. He had no urinary symptoms at all, and he had advanced prostate cancer at presentation. There's been a lot of work going on in Manchester and London, where they take these vans into the community. They do like quite a holistic wellness check, but as part of that, they check men's PSA as well. And that's been really well received in both Manchester and London. Myself and Linda, we looked at doing something similar in Leeds, but the public health team weren't hugely keen for not unreasonable reasons. But I think in all likelihood we're going to see. Well, the Transform trial is a huge prostate screening trial which is being launched by Prostate Cancer UK and the NIHR. This is going to cost £42 million. They're going to need buy-in from primary care as well. And I do think in the next 5 or 10 years, we will see prostate cancer screening. because, as I said, from my point of view, I think the pendulum has tipped in favour of early PSA testing. So what do we want to achieve? Well, I'd like men to consider their own risk of prostate cancer related to their ethnicity, their family history, their age. I want to break down some of the barriers relating to access to PSA testing and some of the hesitancy and reluctance from patients to come forward. I'd like men to know that the DRE is optional, and that men over 50 are entitled to a free PSA test if they request it, and if they obviously understand the pros and cons of PSA testing. We're hoping to educate primary care staff such as yourself in the fantastic advances we've made, particularly relating to MRI and transperineal biopsy. And ultimately, I'd like to see this graph tipped on its head, to be honest. And the fact that 1 in 5 men present with advanced cancer at presentation in northeastern Yorkshire, and it's nearly half that in London. Something's going wrong, isn't it? So next steps, Lauren and Linda have got their work cut out. They're going to be doing focus groups and interviews with men from target groups to try and get some more information. They're looking at doing surveys or focus groups with primary care staff such as yourselves as well, and ultimately looking to develop some resources to embed the learning from this project. So still lots to do. If you've got any more information, any questions or comments that you don't want to raise today, please do email prostate@uni.uk.net. We'd be really grateful for your feedback, any ideas, any criticisms. I've got quite thick skin, so if you disagree with anything that I say, please do let us know.